Hello, everyone. Welcome to Doc Talks. I'm Dr. Manju George, the Scientific Director of Paltown, the nonprofit that supports Town. Today, we have Dr. John Strickler with us, who will talk to us about HER2 targeted therapies. But before we start, I was kind of interested in knowing how you got to GI oncology and to running, such interesting trials. Dr. Strickler, could you give us a brief look into your professional journey up till this point?
Yeah, so when I was going through my medical oncology training, I knew I wanted to be in academia, and I wasn't sure which field to choose. And, one of the things that spoke to me about GI oncology and colorectal cancer research is that while we've made tremendous progress in personalized and targeted therapies, there's still so much more progress to make. And for me, it felt like an area that was very exciting, innovative, and an area that still needed so much more done. So for me, I saw it as a challenge and a thrill to be part of a community that has really made only, up until I finished fellowship, only incremental improvements in the outcomes that really matter to us. And I wanted to bring in more chemotherapy-free regimens and innovative regimens. And through my time on faculty, I've seen this vision come to fruition in several cases where we've been able to move away from chemotherapy into chemo-free regimens. So that's been exciting for me to be part of that, and something that has really fueled my desire to continue working in this field and make breakthroughs.
Okay, nice to know. And other than taking care of patients and running clinical trials, what do you do to have fun?
Well, I have a family that I spend most of my free time with, and enjoy going jogging when I get my own personal time. But usually when I'm doing something for fun, I'm doing it with my kids, either traveling or hiking or, going to sports games with them or whatever they're interested in. So that's how I spend my time.
Okay, nice to know. Okay, then let's get started.
Absolutely. So my topic here is HER2 as an emerging target in patients with metastatic colorectal cancer. And I wanted to start first with, what inspired me to get into GI oncology and in research. And really, it's this promise of personalized medicine, this idea that knowledge of a molecular profile can potentially be used to identify patients for the right treatment at the right time. So that's not just avoiding ineffective treatments, but also finding, based on the molecular profile, what's going to be active and targeting that without chemotherapy. So getting same or better results without all the side effects that we know about with conventional chemotherapy. So that's been kind of my fuel from day one in my area of research. And during my time, what we've seen is a real substantial change in how drugs are developed. In the olden times, like 10 years ago, we had this traditional model of drug development where we would take a large group of patients and randomize them to intervention A or intervention B, and we would squint our eyes on the Kaplan-Meier curve to see who did better. And based on that small incremental benefit, we would see FDA approvals. But that was not a biomarker-oriented approach. That was more just an all-comers approach. With the personalized medicine model, we have a radical transformation in how we do research. Now we're taking a very small group of patients, and with a molecular analysis of tumor, assigning them to a precision medicine approach. And what we're seeing is massive benefit in these highly selected patients, where it's not even ethical for us to randomize them away to the standard of care, because this intervention is so much more effective than the standard of care that no one would agree to go on the standard of care. And increasingly, thankfully, the FDA is looking at this data without control arms and approving these therapies. So this is the new era in which we live. And that's the framework in which a lot of this work was done in HER2. So going back to the end of my fellowship was in 2011. And at that time, we had one actionable biomarker, and it was the KRAS mutations. But it wasn't an actionable marker, it was inactionable, meaning if you saw it, you didn't do something, you didn't give an anti-EGFR therapies. Fast forward to 2022, we've got a much more interesting pie with all different kinds of slices. And this pie is growing every month as we find new targets, new things that are actionable. The encouraging part of this is that the no biomarker group is shrinking, and I hope it will continue to shrink in the future. The slice of the pie that I'm going to focus on today is, of course, HER2 or HER2 amplification. So with that, I will go forward with this presentation. So how do we get to HER2 as an actionable target? Well, HER2 has been known about for many, many years, and it was even studied almost 20 years ago. So trastuzumab has been around for over 2 decades, and the natural question is, what happens if we give trastuzumab to a patient with HER2 positive colorectal cancer? Well, this was done and published by a colleague of mine, Dr. Ramanathan. And interestingly, even though the response rate was quite high for the combination of FOLFIRI and trastuzumab, they had partial responses in 5 out of 7 patients. The conclusion of the paper is that the low overexpression rate of HER2/neu in colorectal cancer limits the usefulness of this biomarker, so there's no point developing treatments in this area. So this was 2004, and with that, the target HER2 was thought to be undruggable in colorectal cancer because we'll never find these patients. Well, we can thank the Italians for resurrecting HER2 as a target, but there's a circuitous story to how we got to HER2. And it starts with EGFR. And this is a figure out of the New England Journal of Medicine showing how EGFR works. So with my pointer here, you can see that this is EGFR, which is a so-called receptor tyrosine kinase. And we have drugs for this. We've got, well, let me back up. EGFR is a highly expressed in colorectal cancer, and it drives some key features of all tumors, so adhesion, angiogenesis, cell proliferation, and cell survival. And we have 2 drugs that treat that, cetuximab and panitumumab. Now, there are some other key members of the EGFR family. ErbB2, otherwise known as HER2, HER4, HER3. So EGFR is a part of this family of receptor tyrosine kinases. And when EGFR is even capable of binding together with HER2 or HER3 to form what's called heterodimers and activate downstream pathways to affect all of these properties that, that can lead to cell proliferation and tumor growth. So this is clearly an important target in colorectal cancer, and one in which we have several therapies in the clinic. Now, the first finding, as I mentioned, that emerged, and this was while I was a trainee, was so-called KRAS exon 2. And in patients with KRAS exon 2 mutations, as shown here, there is no survival benefit for anti-EGFR therapies. But in patients without mutations, you can see here that the patients getting cetuximab or anti-EGFR therapy do much better than those patients who get supportive care alone. So with that came our very first biomarker, KRAS exon 2 or KRAS codons 12 or 13. So this figure depicts all of the different KRAS mutations that can occur in a colorectal cancer tumor. And we can see here that KRAS exon 2, codons 12 and 13, are by far the most common, as shown here. But there are other rare mutations that we see as well, KRAS exon 3 and 4, and NRAS exons 2, 3, and 4. These are very uncommon compared to the standard KRAS exon 2 mutations, but interestingly, they function just the same way. So patients who have a KRAS or an NRAS mutation, regardless of what exon it came from, are resistant to anti-EGFR therapies, whereas those patients who are wild type are sensitive. And that's what this figure depicts, is that the patients who are truly benefiting from anti-EGFR therapies are those patients who have non-mutated tumors, as shown here. So already we're getting a lot smarter about who to give anti-EGFR therapies, but could we be even smarter? Can we find even more mutations that could predict resistance. The next one on the list is so-called BRAF or BRAF V600E. And this was a large analysis of many clinical trials looking at the impact of BRAF V600E on cetuximab and panitumumab or anti-EGFR therapies. And once again, it was found that patients with BRAF V600E mutations get very little benefit from anti-EGFR therapies. So now we've got KRAS, NRAS, and BRAF V600E on our list of therapies that a list of mutations that drive resistance to anti-EGFR therapies. But what else do we have? We've got, in addition to those mutations, there are others. There's MET, as shown here, and something I just mentioned prior, ErbB2, otherwise known as HER2. And increasingly, there's some work being done that has shown that these drive resistance as well to anti-EGFR therapies. Wanted to go into a little bit more about why we think ErbB2 or HER2 drives resistance. This is a plot that shows in green, I'll back up, in orange, all the alterations that occurred in 2,000 patients in the Garden 360 database. And you can see here from the Garden 360 database that ErbB2 amplification is quite rare, or HER2 amplification is quite rare. I then, at Duke, ran a series of Garden 360s to look at what's enriched in patients who progress on anti-EGFR therapies. And here, HER2 was enriched. So we do see higher rates of HER2 amplification after progression on anti-EGFR therapies. And this is a druggable target. We have therapies for this in the clinic, albeit for other tumor types. MET amplification is also enriched in patients who progress on anti-EGFR therapies, but that target is not quite as actionable. So that's why I personally got interested in HER2, is because I was seeing this become enriched or seen at higher rates in patients who had progressed on anti-EGFR therapies. So what do we know about HER2, its biology and its epidemiology? Well, HER2 is a so-called receptor tyrosine kinase, much like EGFR. This HER1 is another word for EGFR. HER2 is in the family right next to HER1 or EGFR. And it forms heterodimers with other receptors, whether it be EGFR or HER3, and activates this so-called PI3 kinase pathway, leading to cell growth, differentiation, survival, and angiogenesis. So we know this is that HER2 amplification or HER2 positivity drives tumor growth. Additionally, what's particularly interesting for me is that there are multiple therapies already in the clinic that very effectively target HER2. So why is it that our colorectal cancer patients have been left out? And that's something that was something that inspired me to start doing some work here. Now, HER2, how do we recognize this? And how, as a patient, would I know that my tumor would be more likely to be HER2 positive? It is typically associated with left-sided primaries. So when I say left-sided, that's rectal, sigmoid, and this area of the colon here up to the descending colon. It's classically where we see these HER2 positive cancers originate. It's not mutually exclusive with RAS or BRAF mutations, but it tends to occur at higher rates in patients who have RAS wild type and BRAF wild type or non-mutated disease. Interestingly, it's not associated with worse prognosis. So we think about HER2 as a bad actor in breast cancer, but in colorectal cancer, not so much. And there's a lot of questions about whether this drives resistance to anti-EGFR therapies. So in terms of how often we see HER2 amplification, it's usually in most large data sets around 3% of patients. Okay, so we'll see it in about 1 in 40, 1 in 30, 1 in 40 patients. And interestingly, when we know where to look, it's much more common. So in KRAS wild type or RAS and BRAF wild type, we see much higher rates of HER2 amplification. So the most common scenario would be someone with a left-sided RAS and BRAF wild type microsatellite stable tumor. That would be where we see rates upwards of 10 to 12%. The next question is, does HER2 drive resistance to anti-EGFR therapies? And this is really the million-dollar question here, and something that we still have very active debates about. So this is work that was done in Italy a number of years ago, a little over a decade ago, where they took a large number of patients and biopsied those tumors and then grew those tumors in mice. And all of these tumors were thought to be KRAS wild type. And they looked at what drove sensitivity or resistance to cetuximab, the anti-EGFR therapy, in their mice. And each bar here represents an individual mouse. And the HER2 positive tumors have a star at the top. And you'll notice very little disease control in those tumors that were HER2 positive. So HER2 negatives were all over here, and they did the best with cetuximab. So that was the first clue here that HER2 drives resistance to cetuximab. And then we have some retrospective data. So this is a large data set out of Italy where they took 100 patients that were HER2 positive and compared outcomes with anti-EGFR therapies compared to those who were HER2 negative. Pretty large data set. They found a few things. First, that HER2 positive disease is associated more with lung metastases than liver metastases, and it was more likely to be left-sided, as I mentioned. And here, this retrospective analysis found that patients with HER2 positive disease did worse with anti-EGFR therapies than patients with HER2 negative disease. So this is our first clue that HER2 drives resistance to things like cetuximab and panitumumab. The group at MD Anderson also looked at their data to compare outcomes for anti-EGFR therapies in patients with HER2 positive disease and found, once again, the yellow represents HER2 negative and the blue represents HER2 positive. And those patients treated with anti-EGFR therapies did worse if they were HER2 positive. They then went back to look at the prognostic impact of HER2 positivity and found that there was no prognostic impact. So they did all the same on first-line chemo, but when it came to giving an anti-EGFR therapy, they did worse with HER2 positive disease, really isolating the effect of HER2 amplification on resistance. So now let's go into some key studies that showed how well these anti-HER2 therapies, which are already approved for breast cancer and in some cases gastric cancer, how they do in colorectal cancer. Well, first, starting with the mouse data, the key point here is that there is some activity for anti-HER2 therapies given alone, but at least in the mouse work, it suggested if you're going to give an anti-HER2 regimen, better to give 2 drugs than 1. And that's the key lesson here based on our preclinical data. So this is what we would expect based on this in the clinic, is that 2 drugs would work better than 1. And that gets us to our very first study that entered the clinic. This is the so-called HERACLES-A trial that was published in 2016. So this was a wonderfully designed and executed study. It took patients who had progressed on at least 2 different lines of therapy for metastatic colorectal cancer. They all had KRAS wild type disease. They had all progressed on anti-EGFR antibodies. And 27 patients were treated with a combination of Lapatinib, which is a pill, and Traustuzumab. Now, this is an approved regimen for breast cancer. The primary endpoint was response rate. And here in this study, the initial data showed a response rate of 30%. So that's a very good response rate where these patients, where the current standard of care has much lower response rates. 84% of patients had tumor shrinkage. And interestingly, they found that 7 of 8 patients who had a response had the highest level of HER2 expression, the so-called IHC3+. This is a marker of expression, and that's the maximum level. So that's what's shown here in red, that these patients with the highest level of expression clearly did the best.
Dr. Strickler, can I interrupt for a bit?
Yeah.
Could you please tell us about Trastuzumab versus Lapatinib, like how they act and how, combining them, like a little bit about the rationale?
Yeah. So,
Thank you.
These are very different drugs. Lapatinib, as shown here, is a pill, and it's a so-called tyrosine kinase inhibitor. So it binds HER2, but it also binds other things like EGFR. So it does have a bit more toxicity, meaning rash and diarrhea and some symptoms that limit our ability to give full dose. Trastuzumab, on the other hand, is an antibody, and this one is approved for breast cancer and gastric cancer. This one is a bit better tolerated. It doesn't have the same diarrhea or rash side effects, but it does have, in rare cases, some cardiac toxicity. So it can make the heart function go down in some patients. Pretty rare, but it can occur. So this one is better tolerated, but does affect the heart in rare cases. And then this one is a bit rougher. And in this model, had a bit more activity as a single agent than Trastuzumab, but clearly if you're going to give this, better to give it together, because in these mice models, these tumors did not grow on the combination, but you can see they eventually grew on just the single agent. Does that answer your question?
Yes, thank you.
So, this was really outstanding data out of the HERACLES trial. Progression-free survival was around 4 months. And once again, it was those patients with the highest level of expression, as shown in red, that had the most durable responses. And so while most of us are getting what's called next-gen sequencing done, or NGS testing, whether it be KRAS Foundation, Tempus, and getting that type of testing done to find the HER2 positivity, there is something to be said for this old-fashioned HER2 immunohistochemistry, which has been done for decades, which is able to capture the expression of the protein and is a really good way to see how well this therapy might work, even before you take it. The other marker that they looked at in this HERACLES study is this gene copy number. So expression is how much protein is on the surface of the cell. Gene copy number refers to how many copies of the gene are in the nucleus. So higher means more amplified, and higher means that the tumor is more addicted to HER2. And as you would expect, the higher the copy number, the more addicted that tumor cell was to HER2, and the better the patient did if you attacked that HER2, right? So that tumor is addicted to HER2. And if you give an anti-HER2 regimen, you can really stop the growth of the tumor, and in some cases very durably. So the long-term outcomes of the HERACLES study looked promising. Response rate was 28%. Progression-free survival was an impressive 4.7 months, which was better than our standard of care at the time. Some patients had responses ongoing for over 5, or one patient had a response ongoing for in excess of 5 years. So that's pretty impressive to see. I won't spend a lot of time on this because it's very difficult to explain this, but the key thing to know is that just as KRAS can drive resistance to anti-EGFR therapies, it can also drive resistance to anti-HER2 therapies. So when there's a KRAS mutation or a BRAF mutation, together with HER2 positivity, HER2 amplification, that does drive resistance to our anti-HER2 therapies. And that's what has been shown in the HERACLES study. I won't spend a lot of time on this figure because it is a bit complicated, but that is the key message here, is that KRAS drives resistance both to cetuximab and panitumumab, and in cases of HER2 amplified disease, anti-HER2 therapies. One of the things that I've mentioned before is that copy number refers to the number of copies of the gene. And sometimes we can identify the copy number in blood with a circulating tumor DNA assay. So this group from the HERACLES trial looked at copy number in blood, and they found that those patients in red with the highest copy number in blood also did the best. These are the tumors that are most addicted to HER2 and will be most effectively treated with an anti-HER2 regimen. So that was our first foray into treating HER2 positive disease. The next was this so-called MyPathway trial. And MyPathway was started by Genentech as a way to explore a number of different therapies in a so-called basket or umbrella design. Here, they looked at, in this HER2 arm, the combination of Trastuzumab and Pertuzumab across a broad range of solid tumors. And colorectal cancer was the largest group, as shown here, with 84 patients that went on over several years. And as I said, all patients were treated with Trastuzumab and Pertuzumab, had progressed on at least 2 lines of therapy. And they allowed patients on with any type of local testing was permitted. So patients could go on if they had a Foundation Medicine or a KRAS or an IHC. They did not apply one test as criteria, which I think was very much patient oriented, because we all know that everybody's getting different kinds of tests, and we want to be as accessible as possible with these kinds of trials. And the primary endpoint in this study was response rate. So in this study, as I'll advance to the next slide, the response rate overall was 32%, very similar to what I just showed you with HERACLES. But one of the things you'll notice is that in those patients who had a KRAS mutation, very few responses. So just one response is shown here with the K. Each bar here represents an individual patient. Almost all the responders had no KRAS mutation, or so-called wild type. And the response rate in their initial data was 40%, which is overall very promising. And as we advance to the next slide, the progression-free survival overall was okay at 2.9 months. But once again, when you look at those patients who did not have a KRAS mutation, they did much better, 5.3 months progression-free survival. Once again, really impressing upon us the importance of those KRAS mutations in predicting resistance to these kinds of therapeutic strategies. The good news here is that KRAS mutations are fairly rare together with HER2 amplification. So most of the time, KRAS mutations are not there with HER2 amplification, but occasionally they will be. Moving on now to this next slide, looking at all the potential markers, as I mentioned, I'll just draw KRAS status appears to matter. Those patients who are non-mutated or have KRAS wild type tumors have a response rate that's better than those who have mutations. Progression-free survival also better. PIK3CA status may also matter. So PIK3CA mutations appear to drive resistance to these therapies as well. So that's something to be aware of. The good news here is it does not matter if you've had a prior anti-EGFR therapy or not. The response rate, the progression-free survival is very similar. So KRAS and PIK3CA appear to be important. There have been several other studies that have looked at Trastuzumab and Pertuzumab for HER2-positive metastatic colorectal cancer. I've put all of those trials here on this table. All of them are zeroing in on very similar data, response rates of right around 30% or so. Progression-free survival, I would trust this number the most. The 4.0 months is probably the most accurate number. I will point out that ASCO Taper posted a much lower response rate of 14%, but that's because they probably included a large number of patients who had KRAS mutations. So let's go back to my clinic. As I said, I've had an interest for a long time in understanding drivers of resistance to anti-EGFR therapies. And one of the markers that came up is MET amplification, but the other one is pertinent to this talk today, and that's HER2 amplification. And it became clear that we were identifying these patients, but we didn't have FDA-approved therapies, and we didn't have any options in the clinic. And there were starting to be these hints from the Italians and others that this is a druggable target. So all of my research is inspired by my patients. My patients teach me. And I would say that the most impactful trials come from those people who know patients the best and know what patients are dealing with, both in terms of side effects, tolerability, activity, resistance. And this is an actual patient from my clinic who inspired the Mountaineer trial. This is a 58-year-old guy, and this was all, he permitted me to tell this story. He presented several years back with bright red blood per rectum, fatigue, abdominal pain, and anemia. This is a familiar story to Paltown. And the rectal biopsy confirmed adenocarcinoma. At the time that he was diagnosed, there was no such thing as HER2 testing. We had a hotspot panel that only looked for KRAS, NRAS, and BRAF, and these were non-mutated, otherwise known as wild type. He got standard therapy, which is FOLFOX and bevacizumab, did fine for a while, but then unfortunately progressed, then got second-line FOLFIRI and the anti-EGFR therapy panitumumab, and then went on a third-line regorafenib-based trial. And when I met him, he was quite sick. He was coming for trials, and I obtained a Guardant 360, a liquid biopsy, to look at what was going on with his tumor and understand if he might be eligible for one of our studies. This is what his blood profiling revealed. He had a very classic pattern of p53 mutation at high allele frequency and APC mutation. And then further down, this is HER2, ErbB2, and this 3+ is the highest score possible for somebody with this blood test. So he was off the charts for HER2 positivity. And this was a surprise to me because I didn't know he had it based on the tissue test. So we went back to the tissue to understand whether this was just something that was in the blood only, and we found that the tumor was highly amplified for HER2, and this is by the so-called FISH test. So that we count the number of copies of HER2 and compare it to the center of the chromosome, and this ratio, anything over 2 is amplified, and his was 10.59, so highly amplified. And I said, look, there's nothing FDA approved for you, but I've heard some data from the Italians that this combination of Lapatinib and Trastuzumab might be active. So I applied for access, and he was fortunate because they allowed him access to off-label Lapatinib and Trastuzumab. This was the baseline scan. These green lines represent tumor lesions in his liver. He was quite sick at the time, a lot of pain in the right upper quadrant from these spots. And within days of starting this new regimen, he felt much better. So after 6 cycles of Lapatinib and Trastuzumab, or about 4 months, you can see here the tumors were almost entirely gone. He felt dramatically better. But a few things. First, he did struggle with the side effects of Lapatinib, which include rash and diarrhea. And I was not able to give him the full dose of Lapatinib because of all those side effects. And so that was a frustration. And then the second frustration is that why don't we have treatments for these people, right? This target is just as actionable for a patient with colorectal cancer as it is for a patient with breast cancer. And I wanted to bring some treatments into the clinic. So I reached out to a company in Seattle called Cascadian because they had a new oral therapy that was much more potent against HER2 than Lapatinib, with fewer side effects. And they said, that's a really interesting idea, John. Let's try this in colorectal cancer. The first thing we did was we looked at how well it worked in these lab mice. Well, in each curve here represents an individual mouse model. And what I would point out to you here is that the mice that did the best are characterized here in blue. So right here. And these are the mice that received the Tucatinib+Traustuzumab combo. Much better result than either Tucatinib alone or Trastuzumab alone in all the models. So we felt like there was a strong rationale. It was already working in breast cancer, and there was something here. So that gets us to Mountaineer, which was presented just about a month ago in Barcelona at ESMO World GI. This was a global open label phase 2 trial that was initially started as an investigator-initiated trial in the United States. I initially wrote the protocol and we opened it. Our first sites included Mayo Clinic and Dana-Farber, Memorial Sloan Kettering, Emory, and a few other sites. And this was initially written as a study to look at the combination of Tucatinib and Trastuzumab, no chemotherapy. And we allowed patients on, I'd like to say this is a study by the patients for the patients, right? We aren't going to delay enrollment waiting for some central lab to confirm HER2 positivity. If the patient had a test from any hospital or any vendor that said they were HER2 positive, they were allowed on. And that's very different from many sponsored trials that we're accustomed to, where you have to wait a month to tell you what you already know. All patients had RAS wild type disease because we felt like that was really important as a predictor of sensitivity. And patients had either progressed or developed intolerance to FOLFOX, FOLFIRI, and an anti-VEGF. We did not require progression on an anti-EGFR antibody because the feeling of the investigators is that HER2 drives resistance to anti-EGFR therapy, so why would we force a patient to take it before going on? We presented this initial cohort A result in Barcelona and at ESMO in 2019, and then based on that result, the study was transferred to Seagen, who acquired Cascadian, and they expanded the study for potential FDA registration. So it became a randomized study where patients were randomized to either Tucatinib and Trastuzumab combination or Tucatinib alone. Now, I had concerns about Tucatinib alone because I felt like the data was pretty strong that we needed to give a combination. But in order for it to receive an FDA approval, the FDA wanted to get some sense of the clinical activity of Tucatinib by itself. And in order to make it more palatable to patients being randomized, we allowed patients to cross over from Tucatinib alone to the combination if there was not a response by 12 weeks of treatment. The primary endpoint was response rate. As I mentioned, HER2 is associated with left-sided disease, and that's exactly what we found. Over 80% of patients had left-sided disease. And interestingly, we did find that HER2 positive disease was strongly associated with lung metastases in this model. And it may be that patients with lung metastases are much more likely to have HER2 positive disease. This was a heavily pretreated patient population. So about 80% of patients had received 2 or more prior lines. And some of the prior treatment history is shown here. The response rate, and this is the key endpoint of the study, the confirmed objective response rate was 38%. Now, what do we mean when we say confirmed objective response rate? What this means is that there was at least a 30% reduction in the target lesions, and that response was sustained over 2 scans. So there were many patients who benefited. It was not just 38%. Many patients benefited, but this is a confirmed reduction greater than 30% over 2 scans. What we also found particularly impressive, that those patients who did experience a response, that response duration was quite long. It exceeded 12 months, which is better than what we've seen in other anti-HER2 studies. So we were particularly encouraged by that result as well. So one measure is, of course, the technical response rate by the so-called RECIST criteria, but we can see that there are many other patients who benefited. And in fact, 2/3 of all patients had a reduction in their measurable tumor lesions while on study. So we actually saw 65% of patients experience some shrinkage in their disease burden while on treatment. And there were some patients, as shown here in the light blue, who had a complete response to treatment. So all very promising data that we presented about a month ago. We also found that across a number of subgroups analyzed that there was similar response rates. So response rate didn't matter by age, by performance status, by geographic region of the world. There is a hint here that potentially we can see higher response rates in patients with left-sided primaries compared to right-sided, but this is pretty preliminary data, and we just didn't have enough patient numbers to make firm conclusions about that. Progression-free survival here was also impressive at 8.2 months, with a median overall survival exceeding 2 years. And I will point out that that median progression-free survival in excess of 8 months is comparable to what you would expect out of a frontline chemotherapy for patients with newly diagnosed metastatic colorectal cancer. So remembering that the current standard of care in some cases is things like TAS-102 or regorafenib, where we expect progression-free survival closer to 2 months. This is all very promising data. We also looked at the clinical activity of tucatinib monotherapy, and not surprisingly, the response rate here was much lower. Only one patient responded, but most of these patients crossed over after 12 weeks. So based on this, I think we can say that we observed much more durable and long-lasting clinical activity out of the combination of tucatinib and trastuzumab. Interestingly, though, tucatinib monotherapy still works. We saw a disease control rate of 80%. One of the things that it's encouraging to me as a clinical provider is that this combination of tucatinib and trastuzumab appeared to be well tolerated. Only 5 patients discontinued treatment due to an adverse event, and that includes 1 patient who came off due to COVID-19 pneumonia. There were no treatment-related deaths. Once again, that's something that's so important to us in the clinic, that there were no deaths that thankfully occurred due to the study regimen.
Dr. Strickler, I have a question. So how does tucatinib compare with Lapatinib in terms of how it acts, and also the side effects, like, does it also have the activity against EGFR?
I'm so glad you asked that. So I actually skipped over that point, but I think it's a really important point. On this slide here, this table compares what's called the IC50s, how potent these 3 drugs are, tucatinib, lapatinib, and neratinib, against 2 targets. One is HER2 and the other is EGFR. The lower the IC50, the more potent it is against the target. You'll see that tucatinib has a very low IC50 at 6.9, lapatinib 109. So lapatinib has less activity against HER2 than tucatinib. Then looking over here at EGFR, now most of the side effects people get from these pills happens not because of the HER2, it's the EGFR. So you actually want to see low potency against EGFR. And here tucatinib has an IC50 that's very high, 449. Lapatinib, 48. So lapatinib is 10 times more potent against EGFR, which probably explains why we see so much more rash and diarrhea with lapatinib as compared to tucatinib. There's another drug that's used in the clinic in breast cancer, neratinib, and this one is extremely potent against EGFR. So this was another reason why I was particularly interested in tucatinib, because it does attack HER2 very effectively, but has limited effect against EGFR, which is what we want to minimize the side effects.
Okay, thank you very much.
Yeah,
that was very nice to see.
Yeah, that's a great question. So this table here shows the most common adverse events or side effects for patients who got the tucatinib-trastuzumab combination. Blue represents grade 1 or pretty low grade or mild. 2 represents moderate toxicity. Grade 3 is purple, which means more severe side effects. And we see very little purple. The most common tucatinib-related adverse events here, and this is important to note: diarrhea, fatigue, nausea, and there is some rash even with tucatinib, even though it has much less effect against EGFR. Now, as I mentioned, diarrhea is the most common side effect to expect with tucatinib, but in most cases that was mild. 50% were mild. We saw a more moderate range in 10.5%. Only 3.5% of patients had grade 3 or more severe. Interestingly, there were no treatment discontinuations due to diarrhea. So we notice it, but it's not appearing to impact our ability to treat with it. And only 2.3% of patients had a dose reduction of tucatinib due to diarrhea. So while it's the most common side effect, it appears to be manageable in most cases. We did see a couple rare cases of liver toxicity, otherwise known as hepatotoxicity. We saw 3.5% of patients with increased ALT, 2.3% with increased AST, And what happened in those rare cases is that we would stop the drug and it would resolve over about 3 to 5 weeks. The patients usually didn't even notice that. It was something that we just saw in the labs. And this is another important side effect. I mentioned that trastuzumab can cause heart dysfunction, and this did occur in 3.5% of patients. So this is something not related to tucatinib. This is related to trastuzumab. So if you do, go ahead.
I was kind of wondering with the hepatotoxicity, like how comparable is it with, say, just oxaliplatin-mediated increase in AST and ALT? Is it?
Well, I would say that many patients were seeing very small increases in the AST and ALT. I would say it's, in my own personal experience, more than you would expect with, say, oxaliplatin or irinotecan. The good news here is that it rarely results in a level of liver toxicity that would lead to modification or discontinuation. So it is something to be mindful of, that there are a few folks, unfortunately, who did run into this problem, and it's something that needs monitoring if you're on this treatment. But it's one of these things where you would not notice it or feel anything as a patient.
Yeah, okay. And then here the slide says anti-diarrheal prophylaxis was not mandated. Does that mean to say that it was so mild that patients were okay without treating the diarrhea? Is that what it means?
What it means is that we did not say that everybody needs to take Imodium before they start. We would only bring in the Imodium or Lomotil if the patient developed, grade 1 intolerable or grade 2 diarrhea or worse, right? So we would only bring in the anti-diarrheas if it was, the patient was struggling with that symptom.
Okay, so I think that was like basically language in the trial that you did not mandate anti-diarrheals, right?
That's right. That's right.
Okay.
So this is where we stand in terms of the treatment landscape of dual anti-HER2 therapies. We've got Lapatinib+Traustuzumab, response rate of 28%, progression-free survival is here. MyPathway is Pertuzumab and Trastuzumab, 31% response rate, 5.3 months progression-free survival. And now we've got Mountaineer data, Tucatinib and Trastuzumab, larger group of patients, 84 patients, response rate of 38%, progression-free survival, 8.2 months. So this is, the first two are in our national guidelines, NCCN guidelines, and are accessible. The third, Tucatinib and Trastuzumab, is not yet in our guidelines. I hope it will be soon. But we're not done. We have other anti-HER2 therapies in the clinic. This is Trastuzumab deruxtecan. This is a very different kind of molecule. This is basically Herceptin attached to a very potent chemotherapy that's kind of related to irinotecan. It's called deruxtecan. Destiny CRC01 showed the first data for this drug in HER2 positive colorectal cancer. I will point out that they also looked at the activity for this drug in patients with lower expressing tumors. So this is cohort B and cohort C. And I'll point out that unfortunately there were no responses in their initial data with pretty short progression-free survival. So most of the activity we saw came out of cohort A, which is these HER2 positive tumors, IHC3+ or 2+ FISH amplified. No patients were allowed on with a HER2 positivity by next-gen sequencing. So this did require a central assay. And the good news here is this is a very active therapy. Confirmed response rate in the initial data set was 45%. Disease control rate also very high at 83%. The median duration of response was at 7 months. So that's a meaningful benefit, progression-free survival at 6.9 months. So the initial data out of cohort A looked very promising. Here's the key thing to know about this drug. It is an antibody-drug conjugate. It is attached to chemotherapy, so you can get more chemotherapy-related side effects, things like nausea, decreased appetite, platelet counts, things of that nature. But there's also one side effect to be aware of, and that is interstitial lung disease or pneumonitis. 6% of patients did experience pneumonitis or lung injury from this drug. And in 2 cases out of 78, those that lung toxicity was fatal. So for those patients who do take trastuzumab deruxtecan, it's very important to be alert to that potential risk. It's rare, but that potential risk that typically can come on sometime between month 2 and 3. I will point out that in this study, the Destiny CRC01 trial, most of the benefit was captured by patients with the highest level of expression. So IHC3 plus, high expression, 57% response rate, much lower response rate in 2 plus. I don't have this data yet for Mountaineer. I hope to show it soon as well, so we can put those side by side. The other really exciting, important thing, there were many patients who went on Destiny CRC who had already had trastuzumab or other anti-HER2 therapy before they went on. It did not appear to impact response rate. Response rate was nearly identical whether a patient had had prior anti-HER2 therapy or not, which suggests that you could potentially give this person an anti-HER2 regimen like what we just showed you, and then go on to trastuzumab and deruxtecan if that therapy stops working or is intolerable. So that's an important finding out of Destiny CRC01. There's been some interesting work looking at biomarkers. It does seem like there are a fair number of responders in patients who have KRAS or NRAS mutations. So this might, I say might be an option in patients who have HER2 positive disease and a KRAS, NRAS, or PIK3CA mutation, but the data is still early. So I would stay tuned to that. And then here is our national guidelines as of now. So for patients with colorectal cancer who've had prior first-line chemotherapy, we've got trastuzumab deruxtecan, or Traustuzumab Pertuzumab, or Traustuzumab Lapatinib. All of these are in our national guidelines, and I hope that for those patients who have HER2 positive disease, they will get access to these things, though none of these are FDA approved yet. There are several other drugs in the clinic to be aware of. CW25 is kind of like a Traustuzumab Pertuzumab all in one molecule, and it appears to have some activity. And then there are a number of other therapies in the clinic, though response rate is variable, and I'm not sure how many of these are active trials at the moment. Finally, want to wrap up with a plug for clinical research and to get people excited about what's next. This is SWOG 1613, which recently closed, so we hope to see this data soon. And this is going to be the definitive question on whether to give patients with HER2 positive disease an anti-EGFR therapy. So patients are randomized to standard treatment, that's cetuximab and irinotecan versus trastuzumab pertuzumab. And for those unfortunate people who are randomized to this group, they are allowed to cross over at the time of progression. The primary endpoint is progression-free survival. We've got Destiny CRC02, which is also active but not recruiting. And as I mentioned, we had some problems with treatment-related deaths on Destiny CRC01. So this is looking at a lower dose of trastuzumab deruxtecan. So it's randomizing patients to the 6.4 mg per kg dose or the lower 5.4 mg per kg dose to see which group does better. And the primary endpoint is response rate. And they did allow some patients with RAS mutations on this study. So that will also help us answer that very important question of whether those patients with RAS mutations might do better with this regimen. And then finally, a lot of folks want to know why they can't just start anti-HER2 therapies right at the beginning, and that's what Mountaineer 03 is all about. And that will take all patients with newly diagnosed metastatic disease and randomize them to FOLFOX, Tucatinib+Traustuzumab, or standard therapy, with the primary endpoint being progression-free survival. So look out for that study as well. And then this is my next study coming up. This is for those patients who would have inherent intrinsic resistance to Tucatinib and Trastuzumab, those patients with RAS mutations. And here we put a cytotoxic together with Tucatinib and Trastuzumab, so TAS-102, and this will be opening at several sites in the United States. Once again, this is for patients who have both a RAS mutation or a PIK3CA mutation and HER2 positive disease. So it's a way to make their disease more responsive to Tucatinib and Trastuzumab with the addition of a cytotoxic. So in summary, HER2 amplification or overexpression is an actionable target. I hope everybody is excited about that after this talk. We've got a number of anti-HER2 therapies in the clinic, but we know who does best. It's patients with the highest levels of expression, IHC3+, high gene copy number, and the absence of KRAS, NRAS, PIK3CA, and BRAF mutations. I think that we've seen a number of therapies that have already shown efficacy. And the key question for the physician and the patient is going to be which one to give. Now we've got all these options now. We're going to have to take into consideration the clinical characteristics, the efficacy, what's going on with the tumor mutations to give the best treatment possible. And also encourage trial enrollment. So how do I treat HER2 positive metastatic colorectal cancer now based on all this data? Off trial, frontline, I would still give the standard chemotherapy as shown here, which could be either FOLFOX, FOLFIRI, or FOLFOXIRI, depending on the patient. And then I would only treat for 4 months total on first line. Stop after 4 months, and then move right next into second line. In the right patient, I think Tucatinib+Traustuzumab is a very active regimen, can provide durable disease control in many cases with, in some cases, very few side effects, or at least manageable side effects. So I like this one next. I like to keep Trastuzumab and deruxtecan around as my rescue treatment if Tucatinib+Traustuzumab is not effective or not tolerated. So it's nice to have that as a backup plan. And then where it gets really messy here is out here in the fourth line. So we've got many other anti-HER2 therapies there, but we still have chemotherapy as backup. And then there are some other treatments that are FDA approved as well. Once we get out of this group, then I would strongly encourage trials as well. So with that, I will wrap up. Thank you for having me and allowing me to give this talk. This is a picture from the edge of my campus right here at Duke, where we have a beautiful Duke Chapel and a wonderful campus. Thank you.
Okay, thank you very much. That was an excellent talk. We have some questions in chat. We can see if we can go through it quickly.
Yeah.
I think one common question that patients have is about amplification versus mutation. So for all these studies, it looks like amplification or the level of expression is more important, right? And that's the first part. The second part, what they asked, the question they asked is, does the IHC or HER2 amplification status change over time? And does it make sense to recheck?
So let's start with the first question. There's a lot of terms thrown around, and they are quite confusing. Mutation is currently not thought to be actionable. So if you see a mutation, we don't think these therapies are, we don't have any data to suggest any of these treatments are active for patients with HER2 mutated or ErbB2 mutated tumors. That's not to say that won't be the case in the future, but our current data suggests that mutations are unfortunately excluded from this data, so limited benefit. HER2 amplification or ErbB2 amplification is shown on these next generation sequencing reports. That's your Foundation Medicines, your KRAS, your Tempuses. And that's generally a good marker of sensitivity to these anti-HER2 regimens. But the best marker of sensitivity is HER2 expression. That's actually looking at how much HER2 protein is on the cell. That comes through a test called immunohistochemistry. And there you would want to see 3+ expression as the best marker of benefit. There is also another marker that you'll hear mentioned, which is amplification by FISH. And that just counts the number of genes in the chromosome, and the higher the better. But you want to see a HER2 to centromere 17 ratio greater than 2, but hopefully greater than 4 or 6. And the best responses happen in those people with 8 or more. And that's a ratio of HER2 to centromere 17.
Okay. Thank you for that. If a person develops, ErbB2 amplification after anti-EGFR treatment, is there a trial for them?
That's a wonderful question. I didn't answer the other question about rebiopsy, so I'll come back to that.
Yes.
But it is possible to acquire HER2 amplification after exposure to anti-EGFR therapy. But based on what I know, the therapies we have right now are for truly HER2 addicted tumors. And you would want to ensure that it's not just a low-grade HER2 amplification picked up on a blood assay. You would want to confirm in the tumor tissue that HER2 truly is driving that tumor, because those are the patients that benefit the most. So you could treat a low-grade HER2 amplification with some of these therapies, but I think you'll see the best results if you do a tissue biopsy and you show that it's highly HER2 positive. So, you know, I think that's still an area of active research. In terms of do I rebiopsy, I would say whenever a patient progresses on an anti-HER2 regimen, I would like to know why the patient progressed. And I think biopsy, if it's safe and feasible, is a great idea. But the alternative is to do a liquid biopsy, a blood-based assay, and that will sometimes tell us everything we need to know. So, so we don't always have to suffer in order to get the answer. Sometimes we can just draw 2 tubes of blood and get the answer much quicker and much less painfully.
Okay. Okay. So if I heard it right, what you're saying is that there is a difference between, you know, having a tumor which already has HER2 amplification versus a tumor that acquires HER2 amplification following other therapy.
Right.
Okay. Okay. The next question. For Destiny CRC01, did it make a difference for patients about the amount of time between earlier HER2 treatment?
Can you ask that question again? Sorry.
Yeah, I think it's mainly that people with prior HER2 therapies were allowed on the trial.
Yeah.
Did it matter? Yeah.
I actually don't know that. I don't know the answer to that question.
Okay. Okay.
Yeah.
Yeah, and then I had this question. The interstitial lung disease that you see in the deruxtecan studies, is it like dose dependent? Is that why they're thinking that they'll start with a lower dose in Destiny 03?
Yeah, you know, I think there is a concern that it might be dose related. I will point out that the FDA approved dose level for breast cancer is 5.4 mg per kg. The Destiny CRC01 trial used a higher dose at 6.4. And I think all of us are concerned that maybe the dose chosen is not optimized, right? So that's what drove Destiny CRC02 to actually randomize patients to 6.4 mg per kg or 5.4 to get a better idea of what maximizes both the activity and also the tolerability.
Okay. Okay. Thank you so much. We are like 5 minutes past 2 o'clock,
yes.
And thank you very much for your time. And this was very helpful.
Yeah, my pleasure. Thank you.
Thank you.